So it can be at how many levels? 3 levels. It can be the manufacturer, which is the bone marrow, could be failing. And it can either be primary bone marrow failure, meaning a problem with the bone marrow itself, not originating from anywhere. Or it can be secondary bone marrow failure, meaning the disease could be systemic, such as tuberculosis or a cancer coming from somewhere, but infiltrating the bone marrow. That is called secondary bone marrow failure. The bone marrow can be fine, but after the blood goes into the cell. So you pause, you know how to pause?
Yes.
Bone marrow can be fine. I don't encourage writing when I'm teaching. It means that whatever you're going to write on, it won't be in your brain. I meet you again, you'll be unable to explain because you've written it on paper, not in the brain. You need to train your brain to be recording things. So no writing. So it could be that the bone marrow is fine, it's intact, it's functioning well, it's producing blood, but there's something, once it gets into the bloodstream, the arteries, there's something which is destroying the blood, what we call hemolysis. Okay? And there are so many things which can cause hemolysis. Infective processes and non-infective processes. The most common infective process is malaria. Non-infective processes, so many things, okay, which can cause hemolysis. Some drugs can cause hemolysis. Okay. What else can cause hemolysis? Congenital abnormalities of the red blood cells, sickle cell, if they are sickle shot. Okay. Congenital spherocytosis, but those are common in children. Of course, a few patients, they grow up. Okay, sickle cell disease. Some of them grow up and go to college and become student nurses, like you. So it's not unusual to have a patient with sickle cell on a medical ward with hemolysis. Now, again, maybe there is no hemolysis, but there is a leakage somewhere. How can there be leakage? Women go to their monthly menstrual period. They bleed. Okay? Most of them, the bleeding is within normal limits. The bone marrow is able to compensate. But others, they bleed, okay, what we call menorrhagia. It's very important in a woman with anemia to ask about their menstrual flow and cycle. Is it normal? Do they pass clots? Okay? Because it could be just abnormal physiology, okay, of the menstrual cycle. Or in a medical ward, it could be somebody who bleeds from the nose frequently. There are some who are just born with fragile capillaries in their nostrils, especially if they are nose picking. There are those people who have bad manners, they're always poking their nose, so they bleed. Okay? Or it could be that they have esophageal varices as a complication of liver cirrhosis, which is common in Zambia. Liver cirrhosis is very common for one or another reason. It could be related to storage of grains, could be related to schistosomiasis, so on and so forth. It can also be that they could be bleeding inside. Peptic ulcers. So it's important to ask about history of peptic ulcer disease, epigastric pain, which is worsened or related to meals, either worsened by being hungry or being improved when they eat. Okay? And characteristically, those who have peptic ulcer disease will be passing dark stools, what we call anaemia. Or indeed somebody can have bleeding hemorrhoids, but which is a surgical problem. Or it could be that the clotting cascade is confused. Okay, they have low platelets for one or another reason. Or they don't have enough clotting factors, the vitamin K dependent clotting factors, which are manufactured in the liver. So any problem which affects the liver can lead to the So those are some of the examples. So we've mentioned, so when you are taking history, you need to bear in mind the causes, so that you ask questions which are appropriate for bone marrow failure, questions which are appropriate for hemolysis, and questions which are appropriate for bleeding. Bleeding is the easiest, not so? Yes. You hurt yourself. Are you bleeding anywhere? Not so. Are you bleeding from your mouth? Have you vomited blood? Have you coughed up blood? Are you passing blood in urine? How are your periods? When was the last period? Were they heavy? Did you notice some clots? How many days did the menstrual flow last? What's the color of the stool? Okay, so don't suggest and say, are they dark? Just say open-ended question. What's the color of the stool? Have you passed worms recently? Because worms suck blood. Okay? Because concealed bleeding. Worms are sucking and bleeding inside. Do you have any pain in the stomach? You're asking about ulcers. If you have pain, what makes the pain worse? Is the pain worse after you eat or when you're hungry? Have you noticed pain? What makes the pain better? What relieves the pain? So meaning you are asking about, the patient may not know ulcers, but they may know the kind of pain they have. Okay? It's you to conclude and say most likely this patient has gastric ulcers or duodenal ulcers from the history. Good. So you take the history appropriate for bleeding. It doesn't take long. Then for hemolysis, this guy is asking about fever and yellowing of eyes. Have you know this guy on physical examination? Even as you are taking history, you can see that she's not jaundice. So the chance of having hemolysis is very slim. It's the easiest history to take and physical exam to do. Then bone marrow. To build hemoglobin, you need the heme and the globin part. The globin part is a protein. Okay? It's a polypeptide. Then the heme part is the iron part. That's where you find the metal, the iron. So for you to have hemoglobin, you need proteins and iron. So meaning nutrition history is very, very important. Somebody with malnutrition can end up with anemia. Somebody who's chronically ill can end up with anemia because their appetite is poor, they're not eating enough because they're chronically ill. What we call anemia of chronic illness, which is common in those who are chronically ill, those with TB, HIV, and so on, and cancer. Are they vegetarians? Because vitamin B12 is very important in the absorption of iron. It improves the absorption of iron. So if they are vegetarians, you know, vitamin B12 comes from meat and meat products. So they can have vitamin B12 deficiency. So that is how you take a history. So it's difficult to take a focused history when you don't know the causes of certain signs and symptoms. So the other way of preparing to flag a patient or patients in a medical lab is to read on the category of symptoms. Anemia is a symptom, the sign of a symptom. And so you read on the causes, so that when you find a patient with anemia, you take a focused history to focus on those three stages in terms of causes of anemia. Even when it comes to physical examination, you are focusing on those. For bleeding, you are checking the orifices, not the nostrils. Are there any clot signs of bleeding? The mouth. maybe she vomited blood, some clots will remain in the mouth. So you're checking for that. Okay. Signs of bleeding. Does she have concealed bleeding? Is there tenderness? There's tenderness, generalized tenderness, suggesting peritonitis. When you aspirate, is she bleeding it? Does she have hemoperitonea? Okay? Which can be due to so many things. If it's women, pregnancy, rupture, can be one of them. If it's somebody who was in an accident, it can be a ruptured spleen. Okay? That's how you proceed. So physical examination again, checking. There are those conditions again which infiltrate the bone marrow. Lymphomas, for example, they are likely to increase the size of the spleen and the liver. Okay? Some leukemias, the lymphomas, they will increase the size of the spleen. If somebody is repeatedly having bouts of malaria, the spleen increases in size because malaria is killed in the spleen. So if you are having repeated bouts of malaria, you are overworking the spleen. It's like you are lifting weights. So the muscles start going. The same thing happens to the spleen. What we call, previously we used to call it tropical splenomegaly. Now it is called what? Hyperactive malaria spleen. That is the new terminology. Okay. Good. And what is the treatment? The signs of hypersplenism. We call the symptoms juice pregnant. Okay. So physical examination. Then if you're suspecting leukemia, you check for signs of leukemia as well as you are checking. You confirm anemia by checking the hands and the soles of the feet, the palms of the hands and the soles of the feet. So when you're examining, you're comparing, you're assuming that you have normal hemoglobin. Then you're saying, how's your issue? It's either she's anemic or I have polycythemia. The HD is usually high. I think I need to donate some blood. Quite right. Yeah. So when you're examining the soul, you compare. It's in an exam, you compare. Okay? In the nails, what are you checking for? Okay? If it's anemia.
Capillary refill.
We're talking about anemia, signs of anemia. You are checking the color of the nails. Are they abnormally white? Okay? If they are abnormally white, we think this patient has liver cirrhosis. Then again, the shape. They are nicely supposed to be curved like mine. Ideal physiological mind. So, but if they are flat, you're hiding your fingers. So if they are flat or they start having depressions on top, like a spoon, then it's a sign of iron deficiencies. Okay? So there's a lot you can see without even aspirating blood to take to the lab, just by examining the patient. Okay? If they have sores at the corners of the mouth with a smooth tongue, then signs of iron deficiency. Okay? Some of them may even have difficulties swallowing. What do we call that syndrome? Dysphagia, but the syndrome of iron deficiency with dysphagia is called what? Plummer-Vinson syndrome. Okay? Plummer-Vinson syndrome. Okay? Plummer, So that's how you examine the patient. Then, if it's leukemia in the mouth, what are you looking for? In addition to the color, you're also looking at the gums. some leukemias, especially lymphocytic, chronic lymphocytic leukemia, will increase the size of the gum. There will be gum hypertrophy. Okay? Vitamin B12, what does it do to the tongue? It looks like beef, what we call beefy tongue. Okay? You've seen beef before? A cow or beef? What do you eat? A cow or you eat beef? Okay. Yeah. Then as you go down, you're examining from head to toe. Axillary, you're checking for lymph nodes, cervical lymph nodes, because lymphoma, TB, cancers will enlarge lymph nodes. And these can infiltrate the bone. The sternum, you're checking for sternal tenderness, as in leukemia. Leukemia can cause sternal tenderness. Then, of course, abdominal exam, enlarged spleen and good. Sometimes, if it's liver cirrhosis, the liver will be shrunk. Check for liver scan. So that is forecast physical examination for a case of anemia. Forecast history taken for a patient with anemia. One you write suspected leukemia. That one you write pneumonia. Make a summary. There's a high chance that the whole time that you'll be attached to this one, those are the cases you see. What will be changing will just be the names of the patients. Today we have how with anemia. What's her name? In a week's time. Very good, reading the same thing every day. Very good. So that's 150. So today make a summary of the cases start with, and that's your syllabus. And B, show me, I'll pass through. I want you to show me the list of the cases. If there will be a deviation, there will just be one or two. Pass or minus. And that's what I want you to do. Those who are doing scratch, one strand, vitals very important, and nursing fundamentals. Okay? Reading vitals, you can't know what is abnormal when you don't know what is normal. Know the normal range, and to be easy for us to discuss the abnormal. Okay, good. So this one, but it can also be sideroblastic anemia. Not that somebody is bleeding. Sideroblastic anemia is associated with lymphoma, cancers, MCV as well. So MCV or microcytic anemia is not equivalent to iron deficiency. Yes, it's the most common, but you need to get to the bottom. So meaning the next step you do is to do the iron studies. Okay? You do serum iron, transferrin, and serum ferritin, as well as total iron binding capacity to determine is it really iron deficiency or something else. Most of the times we don't get to that. We need to get to the foot. Okay? Then if it's the normal MCV, it can be hemolysis, or it can be anemia of chronic illness, will cause normocytic anemia. Then folic acid deficiency, vitamin B12 deficiency, intrinsic factor deficiency will cause macrocytic anemia. Okay? Good. Any questions? So this blood count, and from the blood count also you're able to look at the white cells. Are they high? Or are they, in leukemia they will be usually very high, more than 30,000. Okay? The white cell count is. Or you can have what we call a pancytopenia. All the three cell lines reduce. Red cells, white cells, and platelets. This is normal. Platelets, the normal range is 150. The MCV is 9. So this is normocytic anemia. Okay? So meaning you are not suspecting vitamin B12 deficiency, folic acid, or not even iron deficiency. So you look for diseases which cause normocytic anemia. So it helps you to narrow the possibilities so that you focus on those in terms of further tests, so that you don't waste the money for the patient. If it's bone marrow failure, the cell lines, all of them will be low. The next test you do is peripheral smear. You see, are there any abnormal white cell count, or white cells in the blood, suggesting the kidney. Okay. Then you also do a reticulocyte count. If there is bone marrow failure, the reticulocyte count will be normal. What is the normal reticulocyte count? It's 0 to 3%. If the bone marrow is normal, then the reticulocyte count will be high, because those are premature red blood cells. The bone marrow will try and compensate by producing more red blood cells, and the premature ones will leak into the blood, and that's the high reticulocyte count of more than 3%. So that's how you use. I think we've talked. Let me just address the next one. So this one, what were you planning?